Wait, just give me a second. Veronica, what's that? Down behind there. Hi, everybody. Thanks for joining us for the third day of the Global School on Refugee and Migrant Health. We'll be starting in a little under 10 minutes time, so please hold tight and there'll be another announcement soon. Thanks very much.
Sorry. Good morning, good afternoon, and good evening to all of you. For those who are here physically present with us in the room, or also a warm welcome to all those participants who have joined us online. And I welcome those who continue to support us over the past few days as we embark on this journey on the third global health for migration health. So we're on the third day, and allow me to recap what we have done so far. On the first day, we have looked at the capacity building for health systems response to refugee and migrant health needs and rights. Yesterday, we had a sessions focused on building capacity for addressing the gender dimension of refugee and migrant health. Today, we focus on building capacity for culturally pertinent healthcare. And before I'd like to proceed, I'd like to, first of all, welcome Mr. Mohammed Minazur Rahman, the Refugee Relief and Repatriation Commissioner, RRC of Cox's Bazar under the Ministry of Disaster Management and Relief. Welcome, Mr. Rahman. I'd also like to acknowledge Madam Ajuman Ara, the Joint Secretary of World Health Service Division from the Ministry of Health and Family Welfare. Well, welcome to you, Madam. And Dr. Toha Mia Ara, Health Coordinator for the RRC as well. So warm welcome to you. Why is building capacity for culturally pertinent healthcare important? You may wonder. Well, I think we all know, but what comes up to mind is that people from different cultures, traditions, and backgrounds have different needs. And if we health workers are not sensitive to them, first of all, we will not be able to understand them, but more importantly, we will not be able to help them address their health needs. And second of all, if health workers do not understand or respect or are sensitive to the cultural differences that we have, they will not be able to communicate to them. It can be language, it can be interpretation, or it can even be behavior. And so at the end of the session, the 3 sessions today on day 3, we'll be able to answer all of this. And at the end of the day, we're all better educated and we'll become more knowledgeable about being culturally sensitive and pertinent to healthcare. Before I proceed and invite Dr. Santino, there are a couple of housekeeping things that I'd like to share. First of all, at the end of the session, there's a QR code which will be displayed for all the participants to scan and take part in our survey for day 2. The link will be attached to the chat box and will be sent by email. As part of the global school, participants' experiences are highly valuable and valued, and this would use to improve and for us to be better in future projects, and we would be very delighted to have all the entities kind, insightful, honest feedback on all the sessions. This is also to say that all the recordings, presentations, and video reportages will be available on the events webpage, which could be accessed towards the end of the session. There's a Q&A session at the end, and attendees are invited to write their questions in the dedicated Q&A section, specifying to whom the question is addressed to, and possibly even identifying who you are and which organization you work for or represent. Now I would like to proceed and welcome Dr. Santino Severoni, PHM Director, for introductions and taking us to day 3. Over to you.
Thank you, Edwin. Just a couple of considerations and observations. Indeed, I fully agree, it's an exciting journey, which is made exciting by the high quality, I have to say, of the contribution we received so far. Even myself, I was not fully brief of the all video, all the reportage, amazing. Some of them really touching also in terms of content and so on. All this, in my view, is also certified by the wonderful participation in presence and in remote. I'm keeping looking with attention to the numbers, not because it's so important, but I think it's essential also to keep an idea, to have an idea of the sentiment of what's going on, if we are fulfilling the expectations to the audience. And I'm extremely pleased and thankful for all those which are keeping following us. Yesterday, we had over 800 people following the entire session, a very technical session, which approach the competency from a very specific competence requirement. Today is more broader discussion, but not less important. The cultural element, actually, when we were in the process of developing the global competency standard, was interesting to see the countries that have a different level of acquired competence already on this topic. Many countries that are already systematically using cultural mediators or translators or facilitators for addressing the diversity and the complexity and the challenges that navigation of the health systems might require, especially when we have a different audience, a different typology of patients and in different conditions. Today, this will be stressed and a deep dive thanks to a wonderful contribution from DG Vittorino, DG IOM, Mr. Vittorino. We will have I'm sure, a fantastic keynote speech from Professor Vere, who was also part of the team contributing to the development of the competency standards. And very curious to watch together again the video from Chile and Kenya to see what's going on the ground, which is actually inspiring and been inspiring most of our work so far. So thank you so much. Also, last, thanking those of you, and there are about 500 that provided the evaluation. Please keep doing that. As I mentioned, we really value your feedback, your ideas. Also, I received some personal email from some of you, which I passed on to the team, and we are seriously considering all your observations and recommendations for better next school course in the following years. Thank you very much. Back to you, Edwin, and have a good day of discussion and presentations.
Thank you so much, Santino. Maybe just to supplement, I believe the rich discussion has really been made more valuable because of the question and answers, and the questions that all of the participants, even those of us here in the room, are really very valuable because you really provide a different insight. And it's these kinds of impact, like Santino has basically said, that makes it more enriching and makes us more valuable in terms of taking this journey together. So thank you again, Santino. So with that, I'd like to go to the message from our Director General of International Organization on Migration, Antonio Vittorino. He's DG for International Organization for Migration, and I'd like for him to deliver the high-level address. Over to you, please. Thank you.
Distinguished colleagues, today I wish to speak to you about the importance of cultural adequacy or pertinence in healthcare, which is too often treated as an afterthought. However, this is a real inequality that can translate into serious public health impact, as it can lead to some communities being excluded from services and even hesitant to seek care. Cultural competence and adaptability of health services, or lack thereof, can directly influence how patients and communities understand and perceive symptoms, seek help, comprehend the diagnosis, participate in their own care decisions, and more. At IOM, where we focus on the health and well-being of migrants and their host communities, we aim to support governments and relevant stakeholders in delivering effective, quality care to communities who have diverse languages, literacy levels, beliefs, attitudes, values, experiences, and behaviors. We propose an intersectional approach that takes into account the various needs of people of different ethnicities and origins, people living with disabilities, people of different sexual orientations, gender identity and expression, and sex characteristics. It is also important to factor in the migration experience itself, as this influences risk factors and health outcomes. In developing strategies for culturally pertinent care for migrants, including refugees, it would be a mistake to miss out on the skills, including language and communication capabilities, of health workers who are migrants or refugees themselves. Their experiences of migration and displacement can be essential to inform best practices and support healthcare mediation. In making healthcare more culturally pertinent and inclusive across the board, many challenges remain to be addressed. Migrants continue to face increased health risk exposure due to a general lack of access to care and social services due to a variety of factors. Decision makers also tend to lack reliable data on information on migration health to contribute to developing evidence-informed policies. IOM, as coordinator and secretariat of the United Nations Network on Migration, and its newly established Global Data Institute, remains committed to the generation of timely, relevant data to support evidence-informed policies. As we bolster efforts to strengthen cultural competence in health care for migrants and refugees, IOM looks forward to stronger engagement with you, our partners, as key stakeholders to ensure health providers have the necessary knowledge, support, and tools to truly leave no migrant and no refugee behind.
The high-level address from Antonio. So a couple of things came out, and we're very grateful, and it's very impertinent, which leads on to the first reportage from Chile. Number one is the fact that we have to tap into the experiences and knowledges of the migrants themselves, so that they'll be able to shape the way that we are able to provide healthcare services to them. And number two, the importance of really generating data, collecting data, so that they will be able to feed in and develop evidence-based policies that will be migrant sensitive and will address the health needs of migrants themselves. So thank you very much for that. With that, we'll go to our next session. And this is where I will present the first country case study. As Santino basically said, we have two. So the first one is from Chile. So it is a video reportage basically of how Chile addresses the health needs of the Haitian population migration of about 200,000 of them in the country, and how the healthcare workers were able to identify the problem and find a solution and providing the needs for them. So over to the video, please. Thank you.
La migración haitiana se compone en Chile, en la actualidad, de aproximadamente 200.000 personas. La discriminación, prejuicios, explotación laboral, precariedad salarial, dificultades en relación a la vivienda, situación migratoria y problemas en el acceso a atención de salud han hecho de esta experiencia migratoria una situación compleja que debe ser abordada desde una mirada multidimensional. Como respuesta a este contexto, se desarrolló en Chile el curso Sensibilización de Equipos de Salud para el Acceso y Atención de Población Haitiana en Chile.
Este curso nace de la cooperación internacional entre Chile y Haití, de los ministerios de salud de ambos países, y busca fortalecer las capacidades de los equipos de salud del país para sensibilizarlos en la atención de personas migrantes haitianas en nuestro país.
Este curso surge como una necesidad evidente ante la situación que estábamos viendo en los centros de salud. Un aumento de la población de origen haitiano que puso ante un desafío no menor a nuestros funcionarios de la salud.
Desde el Ministerio de Salud se identifican barreras en el acceso de la atención de las personas migrantes internacionales, ¿no? Sobre todo las personas haitianas porque tienen otra lengua, tienen otra cultura y a veces el profesional de la salud, por desconocimiento, no los trata bien o les niega el acceso a la atención de salud.
Se encontraban frente a una situación bien particular porque debían atender enfermedades que en Chile no existen y por otra parte no eran capaces de comunicar con estas personas no tan solo en términos lingüísticos, sino que también en términos de comprensión de la cultura que ellos traían junto consigo.
Entonces se hacía necesario un curso como este, con estas características para fortalecer las capacidades que teníamos. Y ahí se le pide ayuda a la Organización Panamericana de la Salud para que pueda apoyar este desarrollo de competencias interculturales en salud.
Generalmente las dificultades que tienen las personas migrantes acá, desde un principio no tienen tan claro que tienen derecho a las atenciones y tampoco saben cómo funciona nuestro sistema de salud.
El idioma es una barrera muy complicada y también hay muchas diferencias culturales con respecto a cómo acceden ellos. En el caso específico de los haitianos, por ejemplo, ellos tienen una manera de acercarse a los servicios de salud que es muy distinta a la nuestra.
La gente que llega a este país desde Haití viene de un contexto en que más de la mitad de las personas nacen fuera de los hospitales, en que no han recibido atención médica y que no conocen la medicina preventiva.
Y además yo sumaría los prejuicios que tenemos nosotros. Los chilenos en general y en particular el personal de salud también tiene muchos prejuicios en relación con los migrantes y la población que necesita atención de salud.
El curso lo construimos con gente de Haití y con la ayuda de personas que tenían las competencias en materia de pedagogía, que creamos este curso para poder transmitir estos elementos que son culturales, pero a la vez son prácticos.
Yo soy Bebeldre Alexandre, llevo 3 años y medio viviendo en Chile.
Mi aporte fue algo importante porque yo soy haitiana. En el curso se evaluaba cómo es un haitiano, la cultura de nosotros, las enfermedades que existen en nuestro país, cómo vemos el sistema de salud acá en Chile, cuál es la realidad que vivimos como haitiano, como persona necesitada de atención de salud.
El mandato de OPS para nuestro curso era sobre particularidades clínicas, epidemiológicas y culturales de la población migrante haitiana en Chile. Y basado en eso nosotros creamos 4 módulos para el curso. El primer módulo era sobre interculturalidad, paradigmas y cultura. El segundo módulo era sobre salud sexual y reproductiva y conocimos un poquito de la atención de salud para las mujeres embarazadas en Haití. Y ahí tuvimos el apoyo del Fondo de Poblaciones de la ONU, que el organismo se llama UNFPA, y nos disponibilizaron videos, grabaciones de la gente atendiéndose allá y relatos de matronas que atendían a haitianas. Y el tercer módulo era sobre enfermedades transmisibles y ahí abordamos VIH, tuberculosis, COVID. El curso fue desarrollado en plena pandemia, entonces no podíamos no hablar del COVID. Y finalmente un cuarto módulo que era como una recapitulación de los contenidos del curso y una evaluación que agrupara todo lo que habíamos visto.
Cuando te van mostrando como un área de estudio, digamos, cuál es el contexto histórico en que, en este caso del curso que fue sobre Haití, sobre las personas haitianas, eso te da una mucho mejor comprensión de cómo, de qué es lo que uno puede esperar, digamos, o qué es lo que ellos a su vez pueden esperar de nosotros como centros de salud.
Y por otro lado, el curso es sumamente valioso en términos de dar mucha información de lo que no vemos, que es la realidad de la salud en Haití.
Y uno de los elementos más importantes del curso fue la interculturalidad y el lograr imaginar o concebir de alguna forma cómo una persona que estaba en Chile estaba pensando la relación con el centro de salud.
Yo creo que es importante, es importantísimo que se hagan este tipo de actividades y que ojalá que llegue a la mayor cantidad de personas posible.
Este curso ha ayudado a las personas a ver a los migrantes, sobre todo a los haitianos, cómo ven, cómo perciben la salud. Entonces, eso ha ayudado mucho a esas personas a entender mejor el haitiano para poder brindarle una mejor atención de salud.
Como fue tratado el curso, yo creo que fue muy, muy positivo.
Y es un desafío para nosotros. En el Ministerio de Salud se quiere crear un plan nacional de capacitación en salud intercultural para que todos los profesionales de la salud, y no de la salud también, o sea, desde el guardia, el portero que está en un centro de salud, tomen este curso y puedan desarrollar estas competencias interculturales.
Comprendiendo la naturaleza de nuestras diferencias, acogemos de corazón a nuestros nuevos habitantes.
Thank you for that video. As we all appreciated such a beautiful video where the government of Chile, along with the Pan-American Health Organization of WHO and the Country Office of Chile, produced this video to highlight the fact that it is important for health workers to understand and be sensitive that the Haitian migrants actually had different needs. And through the course that they developed called the Awareness of Health Teams for Access and Healthcare of Haitian Population in Chile, they were really able to open their eyes and realize the fact that if they're not able to understand and look at how Haitians are seeking healthcare from their point of view, they will never be able to understand why they're not accessing healthcare in Chile. And of course, it's an eye-opener as well that the Chilean health workers realize that they have to be able to be sensitive to their needs to be able to really help them. So it's a beautiful one, and it's really very, very fitting to what we are talking about today. With that, then, I'd like to invite our keynote speaker to provide her address. So Professor Jo Viri is the Associate Professor for African Center for Migration and Society, a University of Witwatersrand in South Africa. She is very passionate about, she's very passionate and very experienced in the area of migration health. And she's very passionate and committed to generating knowledge and responses to migration health and well-being. So we're very fortunate and privileged to have her as our keynote speaker. So with that, I'd like to invite her for the address. Over to you.
Hello, everyone. It's wonderful to be with you, albeit virtually. My name's Jo Viri. I'm an associate professor and director of the African Center for Migration and Society, where I coordinate the Migration and Health Project Southern Africa. Today, as part of the theme around building capacity for culturally pertinent healthcare, I'd like us to think about the differences between a migrant-sensitive response and a migration-aware response. The field of migration and health, as you're all very aware, consists of 4 key areas. Firstly, migrant health, so the health of individual migrants. Secondly, thinking about the ways in which migration can affect the health of populations, so a public health response. Thinking about systems responses, including obviously healthcare, but also other systems, including immigration management, social development, and so forth. And finally, thinking about global governance processes in the field of migration and health, many of which you're familiar with and will have covered earlier in this course. An effective response to migration and health would encompass all 4 of these components. So any response needs to think about individuals, needs to think about populations, needs to think about systems, and needs to embed all of that within wider global governance processes. A migration-aware approach to health is a whole health system response whereby population movement is embedded as a central concern in the design of interventions, in the design of policy, and in associated research. What's important here is the consideration of migration as a process rather than a focus on individual migrants, which is what we often see when we focus solely on a migrant-sensitive approach to health. So we can think about the differences in these two approaches. When we want to think about migrant-sensitive, it's often an approach that is based at the facility level. So it's often a very localized response that often considers migrants as a vulnerable, homogeneous, and static population requiring specialized, culturally competent responses. Of course, there are often cases where this is appropriate and where we do need to ensure that particular migrant groups in different contexts receive appropriate responses at the level of service delivery. However, we need to be aware that this individual focus and a vulnerability-orientated approach may inadvertently further stigmatize migrant populations. This is not the objective of such a response, but in contexts where xenophobia or anti-foreigner sentiment is high, in the context of increasingly restrictive immigration policies, a focus on migrants as individuals may further fuel some of those sentiments. We tend to see these responses focusing on a population assumed to be homogenous, very rarely including people who are moving internally within a country, citizens moving domestically, and often may be targeted to specific population groups such as refugees or migrant workers or asylum seekers or undocumented or irregular migrants. In these cases, migrants are often considered static. That is, that they're in the place where that particular intervention is being delivered, and the response often focuses on that particular point. Again, there are times where this is absolutely appropriate, but we need to ensure that we're thinking more widely, linking to migration journeys, trajectories, thinking about future needs, as well as experiences along different stages of migration, which may be affecting health outcomes currently. The emphasis is on cultural competency within these responses. Again, very appropriate, but undertaken in an isolated approach where we are seeing a vulnerability-orientated response to migrants in the context of health service delivery. We may again miss more widely associated challenges or needs or responses associated with movement itself. The limited systems response can mean that we see situations where people who are moving struggle to access continued treatment, for example, or continued forms of care. We see challenges when people are moving across international borders. We may also see problems when people are moving from primary healthcare through to tertiary healthcare, for example, or are needing to move between facilities such as detention centres or prisons into the wider community. And particularly concerning is the way in which, through no deliberate intervention, these responses may end up being further stigmatizing of the target population. A migrant-sensitive approach, like any other positive approach within the field of migration and health, is of course a right to health-focused intervention. But we need to be very careful and ensure that we use careful messaging with civil society as well as within government departments and within facilities, that migrants are not perceived as being sick or a burden on services or in a larger number than they are. Inadvertently, so without intending to, some civil society campaigns, for example, may suggest to the wider public that migrants are themselves demanding a specialized service over and above that citizens receive. We know that this is not the case, but it's the ways in which some of these messages may be interpreted. When we're thinking about migration as a movement, when we're thinking about migration trajectories and systems, we can think about how we make our health system response migration aware. And this is where a whole health system response incorporates population movement and embeds it as a central concern in the design of interventions, policy, and associated research. Such an approach is focused on population and public health approaches. It acknowledges and works with the heterogeneity of migrant populations, including considering domestic or internal migrants, that's citizens moving in within their country of birth. And it sees migration as something with spatial and temporal aspects. So recognizing that the needs at one moment in time and at one moment in space are not necessarily going to be the same in the future and are not necessarily the same as what was required in the past. So this whole systems response is one that we can use the framing of migration and health in all policies, which builds on the very established work around ensuring health in all policies. And this would be an approach to facilitate mainstreaming of migration into health governance and health into existing migration governance systems. So it's really about finding ways that we can sell the idea and the importance of embedding health with all in immigration and refugee policies, as well as ensuring that issues of migration are centered in all health approaches. To address this, the WHO recently published a collection of reports that are around thinking through global competency standards for health workers. What's important here is that there is a set of standards, there's a curriculum guide to support their operationalization, and there's also a knowledge guide. And the idea is that healthcare workers globally could use the curriculum guide and the knowledge guide together to develop an appropriate context-specific training program. The global competency standards for health workers incorporate a range of principles. There are 5 domains, the first thinking about people-centeredness, the second around communication, thinking through collaboration in the 3rd domain, evidence-informed practice in the 4th domain, and domain 5 looks at personal conduct. Obviously, I'm not expecting you to be able to see all of these, but the reports and the standards are all available online and really do provide an opportunity for context-specific interventions to be developed to improve the ways in which healthcare workers at the front line engage with migrant populations. This, I think, could also be utilised by people, for example, in departments of immigration or border management, people working in detention facilities and so on, as a way of bringing health into all other policies. So what do we need to adopt a migration-aware approach? So these are some suggestions that are based on research undertaken over the last 10 to 15 years, including a focus on Southern Africa. My suggestion is that we do need to adopt this migration-aware approach. So we need to think about whole health systems responses, and we also need to think about the role of the whole of government and the whole of society in improving responses to migration and health. This we can frame around 4 key areas. 3 of these are part of the WHO's health system strengthening approach, so thinking about leadership and governance, thinking about service delivery, so in particular here, thinking about cultural competencies at the facility level, and thinking about different approaches to financing. All of this, however, and we're all acutely aware of this, is responsive to and affected by different contexts and the ways in which structural violence, particularly as mentioned earlier, xenophobia or anti-foreigner sentiment, as well as other forms of violence, for example, looking at inequities in health outcomes, thinking about the ways in which different groups are able or unable to access safe and secure housing, for example, as well as direct violence and threats of violence. So components that could assist in guiding such a response could, I think, based on the data that we have available, be based on 4 key areas. So the first, at national level, would be thinking about a migration and health task team, which could work to coordinate and bring together the various sectors, both within the state and outside, including researchers, including business. We know that labour migration is a very key area when thinking about migration and health. We need to bring these individuals together to really think about the kinds of cross-sectoral, intersectoral, multi-level actions that are required to improve leadership and governance when thinking about ensuring health in all migration policies and ensuring that we are engaging with migration in health system development and delivery. So an example here would be making use of the competency standards that I just mentioned. When we're thinking about financing, a key issue here is about thinking about universal healthcare coverage, UHC, for example. Obviously, all of these suggestions would be expanded and be ensured to be context specific when thinking about certain spaces. But it's about encompassing cultural competency whilst ensuring that's just one piece of a much bigger approach to ensuring that migration aware systems are developed. When thinking about structural violence, which we know affects the ability to deliver on all of these components, but importantly is affecting the health and well-being of different migrant populations, as we see increasingly restrictive immigration approaches, for example, we need to bring together a whole of government and whole of society response to think about how we can better address underlying structural violence. This, of course, incorporates issues around law and around the right to health, around the ways in which different foreign nationals are given the right to access healthcare services. So we need to ensure that we are considering this at all stages of the development process when we're thinking about developing these kinds of responses. When thinking about structural violence, a key issue is about how do we work to ensure that departments responsible for health and supporting health and well-being of everyone within a particular country or region, how do we tie those responsibilities with, for example, departments that are governing migration, governing immigration, governing refugee and asylum seeking populations, departments of labour working with labour migrants and so forth. One of the key issues that we know is increasingly different migrant groups are finding it hard to ensure that they're able to regularize and continue the regularization of their stay in a given host country. This means that they, for various reasons, might be fearful of trying to access healthcare. They may not have the right to access healthcare, and so on. We really saw this recently in the context of approaches to COVID-19 monitoring and ensuring access to vaccinations. And what we clearly need is something that is often referred to as a firewall. A firewall is a way in which there is a regulated humanitarian response that ensures that we can clearly separate the roles of the healthcare sector from the roles of migration authorities, including those responsible for immigration. And it's argued that by doing this, we will be able to support improved responses whereby all patients, all healthcare users are able to access care safely and securely. I will end there, and I hope that this is helpful for your discussions, and I look forward to any questions later. But really urge you to think about the language of migrant sensitive, the language of migration aware, and seeing what capacity is required to ensure that we have culturally pertinent healthcare available globally. Thank you very much.
Thank you so much, Professor Jo. And we're very happy to know that Professor Jo will be with us later in the Q&A session, where we will be able to discuss further what Jo has just presented. So in the keynote speaker address, it was very clear that Jo was able to actually break down what are the different components of being culturally sensitive and pertinent healthcare providers. But more importantly, what is the difference when we talk about migrant sensitive and being migration aware to the needs of the migrants, and to look at it as a process rather than as a standalone individual approach. So thank you so much, and we look forward to more discussions on that. I see already a lot of movement actually in the chat box, so I'd like to encourage already colleagues, students, and other friends and partners to keep the questions coming so that we will be able to really enrich ourselves to do that. Allow me then to go to the second video today, a case study from Kenya. So in this video, it is really a way to look at how Kenya, with about 500,000 refugees from several countries around Kenya, has been able to provide healthcare services, working with different partners, including WHO, UNFPA, the government, of course, leading the processes, with the Kenya Red Cross, and how they're going to be able to integrate and provide a comprehensive healthcare services, while at the same time being culturally sensitive to the needs of the refugees. So the video, please. Thank you.
I reached to this place, I was really, I don't know what to say. I was really desperate. Even my daughter was like, you brought me into this bush. You brought me into this bush. There are two winds. There are what? I said, my daughter, please, let's bear the condition. He said, no, even the food is not fair. Even the what they are making in the reception, I have no money. I have no money. I said, what can I do? I could just shed tears. Sometimes I just make my heart strong. I said, my daughter, this is the condition. Don't mind of that. Because from there we were fair. She was eating other things. So those are the things. Life was really hard for me. So I got these people of Kenya Red Cross. They were doing like dialogue. I could go there. So they were like, they need other people to volunteer as a mother promoter in village 3. Of course, now I said, I'm just now, yes, just doorman, word, those kind of things. I have to do something. So I ended up taking myself in. We went for the training. I started doing those things. I was forgetting everything. I said, even if I'm not getting any coin, I have to do it because I have to move all in the community. Just talking, tell them, go to the hospital, do family planning, don't produce at home. Just I forgetting everything. I was really very happy. Even up to now, I'm very happy. I feel peace in my heart.
Since the early 1990s, Kenya has hosted nearly 500,000 refugees. Most are from Somalia, South Sudan, the Democratic Republic of Congo, Ethiopia, and other neighboring countries. Large numbers of these refugees in Kenya are actually residing in camps. One of them is in Kakuma, which is located in the northwestern part of Kenya. Then the other camp is in Dadaab, which is located in the northeastern part of Kenya.
In IFO, we normally undertake health and nutrition needs of the refugee population and also surrounding the host community. Refugee Records really supported us through this period through interventions that were set and including primary healthcare, secondary healthcare, and also some aspect of referral. Not to forget the capacity building of staffs and also both auxiliaries. These are support staff who are refugees. Prior to these interventions, there were unmet needs, health and nutrition needs among refugees. We are talking about 2018, 2017, and 2016. We had maternal deaths, ranging from 8 to 10. Currently, we have 0 maternal deaths. That is death that occurred at the facility level. This really shows that the importance of the interventions we did both at community level or at hospital level.
Save mada tulionaga wakati utanenda clinic. Sasa na wenyewe wanakuja wanaangalia wamama wenye wajawazito. Mimi venye nilifundishwa, ikifika wakati wa kwenda clinic, unasai kuenda kwa zile tariki ambayo wamekuelezea kwenda clinic. Sababu haikuwagi mzuri wakati wamekuandikia tarehe fulani na unaenda tarehe fulani, sio mzuri. Sasa ndio maana wanatufuatilia. Tazia mtu anaweza kana sahau. Lakini wenyewe wanakuja nafuatilia mpaka kwenye zile tarehe wanakuandikia mpaka lazima uende.
In this data, actually, it has the capacity to serve this entire made by Kenya Red Cross. We also want to give thanks to the World Bank, who DIP, which has also stepped in to keep this system. But in terms of drugs and human resource, it's really supported by Kenya Red Cross and a few for the county staffs, which also run this theatre.
We capacity build our community health workers working in the nutrition department through trainings, IMAM training, MYCN training, and even taking them out to other agencies where there are trainings that will help them in delivering services to the community. They are also paid a salary approximately of 9,000 at the end of the month.
Kizuri chake ya family planning, huyu mtoto ni kidogo na ukishika mimba mtoto ni mdogo inakuwa mbaya, anaweza akakufa. Unaweza kushika mimba au kujua wewe haujui ukampatia hiyo maziwa mbaya akakufa. Sasa family planning kizuri chake ukiingia unazalia kwa nani, kwa kusabia. Kama ni mwaka 5 mtoto anamaliza mwaka 5 ama mwaka 3, hiyo mwaka 3 unachukua mimba. Sasa hivyo mtoto anaendelea vizuri.
Now, with ongoing droughts, it actually calls for enhanced partnerships, collaborations, and innovations towards increasing human resources, which are actually targeting refugees and migrants' health. There's also a need to increase the capacities for One Health approach. You know, with One Health approach, we can actually be able to bring together all the key players in setting up and empowering the communities that we're actually working with. Then further that also, WHO collaborates with Ministry of Health, the Government of Kenya, Gavi, UNICEF, UNHCR, UNFPA, Kenya Red Cross and other partners to deliver on vaccines, immunization and actually ensuring that they provide a comprehensive package that is supporting the refugees and migrants.
Area of human resource, we need to have a specialized surgeons and doctors. Now are the capacity of the refugees because of the new arrivals and the demands, things are actually increasing, both the host community and the refugees. So if we could have got a specialist, either a surgeon, a gynecologist, an ENT surgeons, we could have appreciated.
Thank you so much. Another beautiful video reportage that was produced, and just a kind reminder to the audience here that all the original videos produced so far, including this one, the 6 videos were produced exclusively for the 3rd WHO Global School for Refugees and Migrant Health. So these will all be available online in the webpage, and it will be encouraged to really look at them because they really provide a very informative and at times even practical ways to move forward. So I'd like now to move to the 3rd session, which is the Q&A. So we have the privilege of having Professor Joe online. Joe, are you there?
I am. Hi, everyone.
Thank you. Welcome. We also have our colleague from HQ, Miriam. Are you there? Miriam Makot, Technical Officer for Research Agenda in the WHO Health and Migration Program.
Yes, I'm here. Thank you.
Great. We also would like to tap into the kind presence of the Commissioner, also Dr. Toha, and of course, the Joint Secretary. Probably she stepped out. Yeah. So I think we have a very rich tapping of resources available to us. So I pass it over to you, James. Over to you.
Thank you very much. So we'll be taking questions from the floor and also from online. Colleagues, please feel to raise your hands and jump in whenever you feel like you need to. Thanks very much. This first question is from Ahmed in Belgium, and it goes out to Joe. Joe, cultural mediation trainings and services can be quite difficult to find at the health service level. What can we do as the health sector to ensure that these trainings and services are more widely available?
Thank you. Would you like me to give some thoughts now?
Yeah, please go ahead.
Thanks. And I saw there were also a couple of questions coming up in the chat box. that were asking a similar question, I think, around the ways in which cultural competency training can or should be incorporated also into medical professional training, for example. And I think that this all links together. And I think that we need to recognize the experiences in the field of migration and health, where we see different migrant groups trying to access biomedical healthcare services. That point in which they interact with the healthcare system is the sort of manifestation, a coming together of multiple different experiences, including of those in the healthcare system. So I think we need to ensure that we're embedding the right kinds of training into professional courses that currently exist. So for example, nursing schools or medical schools, dental schools, etc. But I also think we need to find a way through continuous professional development, CPD courses, the issues around migration are incorporated. We know that many healthcare workers are overwhelmed with just how many continuing professional development courses there are and that they're expected to participate in. And I think that in line with the language of migration aware and trying to ensure that we're thinking about migration across all health interventions, I think bringing migration in as a stream throughout many different sessions and different courses would be incredibly important. And the competency guidelines and the curriculum development are the sorts of interventions that can be used and manipulated to fit into existing trainings as well.
Fantastic. Thank you very much. Do we have any questions from the floor at all? No? Okay, fantastic. So this question is from Dr. Hand Arpat. He's a migration and health physician at IOM in Turkey. And this question sort of goes out to everybody, really. Just building off of yesterday's topics about gender-related health systems, how strong is the effect of having gender-balanced healthcare teams to build culturally pertinent healthcare? Any positive or negative experiences you'd like to share on that?
Santino has volunteered.
Excellent, thank you,
Breaking
Santino.
the ice, but I think colleagues should contribute. I think it is very important. In fact, even in our daily life as a WHO, we are applying this rationale in any staff engagement, new recruitments, and team building. So it's extremely important, especially when then you have to deal with a different cultural context, that both gender are engaged. I don't need to go into specific issue, but imagine to the sphere of gynecology or maternal child health, where the gender, to be equal gender, is very, very important. Thank you.
The question's on gender-based violence?
No, gender-based teams. So the
okay,
importance of gender balance in healthcare teams when it comes to culturally pertinent healthcare.
I will attempt and supplement what Santino basically said. It has to be a given, basically, that there should not be one or the other, but it should be together. And the way to basically live it on a daily basis is really to be having that gender sensitivity in everything we do, be it the way we behave towards colleagues, be it the way we interact with our stakeholders, with the government partners, etc., even in the way we perform our work. So I think the gender teams will kind of remind us to do it, but it's really the onus on us to take that forward. Maybe Joe and Miriam to add. Over to both of you.
Thanks. Yeah, just to add, I think that we, the sort of basic premise on the way that we all are approaching health is around sort of basic rights to health. And so within that, obviously ensuring that there is respectful delivery of healthcare to everyone is key. And obviously gender is an important issue here. I just want to sort of emphasize the importance of making sure we're not reducing gender to a binary. We need to acknowledge that people express gender in different ways. We know, for example, that there are many transgender refugees who are forced to flee countries of origin who require specific services. So I think it's really important that we make sure that we're taking this into consideration and working with communities and organizations that have a long-standing history of working with trans migrants, for example, because that I think is absolutely essential. And the second piece, which is not to conflate gender and sexuality, however, sexual identity is also something that may prevent somebody from seeking care or might provide challenges to somebody who is a healthcare provider. So again, issues around sexual identity, gender identity needs to be brought into this conversation as well. Thanks.
Thanks very much. Miriam, would you like to jump in on that at all?
Thank you so much. No, I mean, I think absolutely agreeing with the points that Joe just raised, and particularly in terms of cultural competence and gender sensitivity as being about also ensuring dignity of people who are accessing care. And I think that not just enabling sort of appropriate access to care, but also enabling that person to present their healthcare needs within the frame of their own gender identity, within the frame of their own language and culture. And certainly just one other point to add, I think it relates to the previous question around the fact that there is also a need for not only training to be about healthcare providers in cultural competency in humanitarian and health systems, but also about educational integration. So within medical training, within health service provider training, making sure that there is not just migration as part of that, but also about cultural competency as being a key aspect of medical training throughout all stages of that, so that individuals, once they actually reach the end of their training, they will be able to approach these topics with the sensitivity that is needed, which will actually improve their ability to deliver care, not just for migrants and refugees, but for all populations with an understanding of the holistic aspects of culture and language. Thank you.
Wonderful. Thank you so much. Miriam, this question goes back to you as well, so I hope you don't mind talking for a little bit longer. It's a question regarding the impact of traditional medicines and therapies in a migration context. Is there any research done on the impact of those, and what can we do as the health service to deal with those kind of issues?
Thank you. I think, in general, that there has been a lot of focus on cultural competency more broadly. In terms of particularly focusing on traditional medicine and therapies, I believe there's a lot more within research and evidence on particular areas such as mental health, for example. But for example, within medical anthropology, this is sort of looking more broadly outside of just the migration health space. Within medical anthropology, there has certainly been a huge amount of work on this topic, not only of understanding, what individuals might be understanding beyond our own biomedical framework, how individuals might understand their own health issues, but also about what are the traditional interventions or treatments that they might have accessed in their country of origin, but also during their in any stage of migration. So I think there is a lot of knowledge there. Sometimes this knowledge, I think, needs to be brought together. What has already been done within medical anthropology on cultural competence, and within medical more broadly medical training, but also then within the specific context of migration, which I think is very key, because we're not talking just about individuals who are accessing care once or meeting a healthcare provider once, but who actually may be accessing care or needing care at multiple different stages during different migration contexts. I'll stop there, but I'm not sure whether other colleagues might have comments. Thank you.
Fantastic. Thank you so much. Is there anyone from the floor that would like to chime in on that topic at all? Dr. Simon, yes, please go ahead.
Yes, thank you very much. Just to circle back on the teams, and I would like to share an experience from the Rohingya camps here in Cox's Bazar. Soon after the influx and the feedback that we got from the communities required us to actually have female doctors in the healthcare facilities through the health sector that was endorsed. And it is actually routinely monitored that each health facility in the camps has a female doctor in order to address some of the sensitivities that which we got as feedback from the communities. And building on yesterday, where we had a presentation from UNHCR, we actually learned that the community healthcare workers in the camps here, majority of them are female, and more so, up to 60%, close to 60% of them are from the Rohingya population themselves. So that sort of tries to cover that element of persons being more gender aware, but also much more acceptable within the societies which they're coming from. That is just an example here that maybe other places in the world could learn from and see if it is implementable. Thank you very much.
Perfect. Thank you. Thank you very much. So this next question actually is building off your experience, Dr. Simon, as well. And it also goes out to Edwin. It's from Ernest. And he is asking, what happens in cases of the massive arrivals of migrants and refugees that need emergency responses? How can we be culturally responsive in such emergency situations? And what happens after these people have remained in the host countries for such a long time? How can we continue to be culturally responsive during protracted emergencies? Thanks.
I will start, and then maybe I'll invite Dr. Simon from experiences in Cox's Bazar. What often happens in an emergency, especially when there's a massive influx, is we react to the situation, and therefore we find ourselves in a lot of challenging, difficult times wherein we have to build on systems that have been established quite rapidly. And by building on top of a system, you actually find yourselves in more problems than none, particularly if you're talking about being culturally sensitive and gender sensitive. So what we're trying to do, and this is the whole global architecture that's being going on now, is why don't we look at preparing countries to be building all these different aspects before any emergency or before any response comes up. So for example, if you're going to prepare a response plan to a massive influx, or let's just say a natural hazard for a flood, we should build into the natural action plan of the government all these different components that will already address the issue of being culturally sensitive and gender sensitive to the needs of the population. So in that way, you already have a very basic foundation to which you can already manage the initial stages, and then you can improve on them rather than being unprepared and you build the items that are not there. Santino and I have discussed about this. The direction now with WHO working with member states and other partners on emergency preparedness and response is exactly on this, that what have we done that we can do better in natural hazards or massive influx of emergency. So it's a work in progress, but the first step of acknowledging that the fact that it is something that has to be built from the beginning is already there. So Simon, please.
Yes, thank you so much, Edwin, and James, and for the question. Related is, for example, in the health sector coordination team at Cox's Bazar, we have a gender in emergency specialist who is specifically recruited to support these issues and is part of the team in the health sector coordination. The other aspect, and this staff supports building capacity of healthcare workers in all facilities to ensure that the issues of gender are not left behind. But more so as protracted, we look at the joint response plans that we developed. In order for them to be considered by peer review teams, they have to have a gender and age marker. And this is further to re-emphasize the need that from the processes of planning and going forward, these are considered. Well, through in such a response, we have other sectors we work with. There's a GBV subsector and protection sector that supports those linkages, and expertise that cuts across all those areas. One other important thing is getting feedback from the communities and making from the people that we are serving to ensure that actually what we are delivering responds to that. So the feedback mechanisms needs to be maintained, but also through other avenues like accounting to affected populations, frameworks, and ensuring that they're implemented and followed. Thank you very much for the question.
Wonderful, thank you so much. And on a similar topic, this question goes out to Joe. It's from Dr. Hassan at Action Center LA La Film. Action Contra La Film, my apologies. So a lot of our colleagues are operating in low resource settings and emergency settings. Out of the two structures the two frameworks that you've laid out for us, migration sensitive services and migration aware services, is one of those to be prioritized over the other? How can people best organize limited resources to achieving those frameworks?
Thanks for the question. What's important is when I talk about migration aware is to acknowledge that obviously key in that are issues around cultural competency and appropriate service provision at the level of healthcare user and facility. But what's important is finding ways that we don't focus solely on that, that we are ensuring that we're thinking about migration as a bigger process and the way that it affects multiple domains of health. Miriam, for example, gave the example thinking through continuity of care, both within countries and across borders. And I don't think it's necessarily about prioritizing one over the other. It's that the migration aware response sort of incorporates the ambitions of migrant sensitive and pushes it further. One of the key things we've seen in South and other Southern African countries is really framing this about how it will benefit the whole population. I think one of the accidental disservices many of us working in the field of migration and health do is to focus only on migrant populations. And what we need to do is be much clearer in the approaches that we're encouraging around improving responses to migration are there to benefit the whole country. So we should be finding ways to intervene in, for example, strategies looking at UHC or strengthening primary healthcare, or specific vertical programs around responding to tuberculosis or malaria, and ensuring within those existing initiatives that we're pushing for an improved response and consideration of migration and the experiences and needs of particular migrant populations. So it's really about saying, this language of mainstreaming is overused and it's a difficult thing to do, but we're not asking states to develop something entirely new. We're not asking for a whole new program. Rather, we're saying, can we get migration into existing interventions? And then this will be a win for everyone who is reliant on those healthcare services. Thanks.
Fantastic. Thank you so much. This is a question to Santino, and it comes from Ursula, and she's from the European Initiative for Migrant-Friendly Hospitals. Are there initiatives to train the top management of healthcare organizations, WHO and health services, about cultural sensitivity? Are there drivers that are happening at the very top level of management?
Well, this is the intention with the school, to be honest. That's why we're really looking very carefully to reach out countries. The idea of having a platform, an opportunity to meet senior policymaker, decision maker, which usually they are not having time to get involved into the details of the issue, is exactly the objective of this initiative. But it's not the only one. Certainly, the question touch on a very interesting perspective that when we go to the health sector, if you ask my personal judgment on the situation, having a privileged observation position from the global perspective, is that health sector still need to make an additional step in getting fully committed on the topic of health and migration. Still, we are having a general attitude to pay attention when we are pressed by an emergency situation, by a situation of urgency. So still the, let's say, untaught way of thinking or perceived attitude in relation to health and migration, that the health dimension is a side effect of the migratory process rather than a founding principle for people well-being and
positive health outcomes. So this means that still we have some road to go. However, if I'm looking also in our back from where we started, the situation is certainly encouraging. We need to be also positive because many countries, they are moving forward. Before there was the question how to promote cultural competence during emergency. In my past experience, I was impressed to see that in a high income setting where I was working, no any contingency plan for any catastrophe or emergency situation was including migrants or large population movement or influxes. And we do know very well what needs to be done. We have a very precise checklist of things which are supposed to be reflected into eventual contingency plan. So the issue is what also Joe was saying, rather than to invent new system, really to be very attentive, really to patrol, to make sure that the issue of dimension is included in the most important and all important action of countries. But again, making long story short, yes, things are changing, but personally, I don't believe we are yet in the place where we should be in terms of understanding, awareness, and capacity. That's why we are dedicating so much effort to this topic. Thank you.
Fantastic. Thank you so much. Any questions or comments from the floor at all? Yeah. Oh, we got one just here.
So my question, should I stand up? No.
Introduce yourself.
Yes.
You can stay comfortable.
Okay, my name is Mohammad Mizanur Rahman. I am a Refugee Relief and Repatriation Commissioner working in Cox's Bazar. Before that, actually, I had been additional Refugee Relief and Repatriation Commissioner since 2017-2020. Regarding the cultural, cultural phenomena and the gap between the service recipient and the service providers regarding the cultural education is very important for the Rohingya community who are living in Cox's Bazar. They came from a country where they were deprived of basic health rights. As Edwin was working there so far, he knows. They were deprived of the basic health rights. They were not actually capable to have the access to the basic education even. So since they are not that much educated, so they are not aware of the health education, health services. So came here with the, some superstitions, some, disbeliefs, misbeliefs. And so, the diphtheria was unknown to our country for last 2 decades even, but they came with diphtheria, they came with measles outbreaks, and we had to face all those, diseases. But the main challenges was that the people, those are not actually educated and the aware of the health services, keeping them on board, taking them on board was the main challenges. So what we did actually, we actually talked to the Majis, the local community leaders, and also the religious leaders to have them on board. The 2 examples I can give you for the lessons actually of this global school. One is the recent, we had a vaccination program campaign for Penta and DTD. So we had a coordination meeting with our camp in charges, and there was a briefing by WHO colleagues, and the CACs organized the several, discussion and dialogue with the community leaders, right from the Majis and the imams and others. Now this is so far the result is that the around 92% our success rate. It is because of the community leaders awareness, and they were on board. Another is that the birth spacing, the one lady was talking in the Kenya camp that we started campaigning regarding the birth spacing, and now the several methods are accepted by the community, and it is around more than 60%. Once when they came here, it was 30% or 33%. It is now 60% more. But my question is to the migration and the health and migration program of WHO. As a country, Bangladesh, we have more than 10 million people working around the globe as migrant workers. And migrant workers' health is a big issue for Bangladesh. Almost every week, we are receiving the death news from our different countries, and dead bodies are being received by their families here. My question to the WHO actually, from this perspective, what are the programs actually you have regarding our migrant people's health abroad? And here in Bangladesh, with the government of Bangladesh, and also the host countries, the other country where our people are working. Thank you.
No, indeed, and Bangladesh migrants are important like all the other migrant population around the world. So programs are not country tailored, but there is an intense engagement, collaboration, and also support going to a number of countries. Of course, prioritized are those with a more pressing situation, like Bangladesh. It's facing challenges with Rohingya, with a refugee situation. There are countries which are having similar reality where the intensity of collaboration certainly is higher, but the program is global. In each region, there is a component which is looking after and working with all member states. So if we want, we can offline provide you also some figures, numbers, and so on. And plus, around the room should be some copy of the World Health Report. There you can find really details on what's going on worldwide for all migrants. Also, the report is valuable because out of the 300, 150 are references. So you can also identify the source of the data. So it's really very informative, very useful to have a baseline picture of what's going on around the world in terms of work on health and migration, which I acknowledge. Ministry of Health, I can say that they start to really get systematically involved on this issue only recently. The main concern worldwide is mostly for those migrants in irregular situation, while the issue of those in regular conditions are different, are usually related to quality of the healthcare services, accessibilities, barriers, so more, let's say, technical elements of smooth functioning of the health system and access. Thank you.
Great, thank you very much both. I just want to jump to one more question from online, and then we'll jump back to the audience. This question goes out to Miriam. What would you say are the most pressing topics when it comes to research gaps around migration, and particularly culturally pertinent migration issues? Are there any areas of information and evidence that really still need to be developed, in your opinion?
Thank you so much. And this actually very much builds on what we at the program are also working on at the moment, which is the first global research agenda on migration and health. So we will, over the next few months, have a process of technical consultations with many different stakeholders in all regions to actually precisely develop the prioritization of research themes, which will be then able to be further used at regional and country level. So I would just highlight this as being an area that we are currently very much working within. In terms of the research gaps that can be already identified, both in literature, academic literature, within the work of different UN agencies. Of course, there's a lot of evidence generated by humanitarian organizations also who are working within different migration contexts globally. I would say that particularly for cultural competence, there is still a need for further evidence on what interventions are most effective within specific migration contexts. So it may be that actually a lot of the evidence that we have at the moment is from high income countries where there might be a higher proportion, for example, of newly arrived migrants and refugees or asylum seekers. But actually what we lack often is that evidence from situations where migrants might be within transit contexts, moving more rapidly between different countries or within a country itself. And these are the sort of contexts where actually what we need is not only to have better research, but also to have a better cooperation and dialogue between all of the different actors who work within those spaces. So not just humanitarian organizations, not just UN agencies, and not just academics, but trying to have a more productive and better dialogue and exchange of information between policy, practice, and academia. So I think, I'm just highlighting that one of sort of transit context, but I think, the same could be raised also in terms of we don't have a huge amount of research in areas such as where there are undocumented or irregular populations of migrants, or those sometimes who are very newly arrived as well. So I think having this understanding of where different migration contexts might need particular areas of focus is very important when we think about evidence generation and research within this area. But I think the last thing that I just want to highlight very briefly is that I think for all of this, something that is raised very much within the World Report, as well as more broadly within the field of migration health research, is the need to include the populations who one is working with. So when we are actually working within these areas, including generating better evidence on cultural competence, actually being inclusive of those communities who we are working with, both within the process of research as well as within the dissemination and actually implementation phases. Thank you.
Fantastic. Thank you so much, Miriam. That was wonderful. I'll hand the questions back to the floor. Can we get a microphone? Thanks.
Hello, I'm Dr. Naila, working as an assistant scientist in ICDTRB. Currently, I'm working in Rohingya camps, particularly focused on severely acute malnourished children. So from my work experience, I found, oftenly I found a religious barrier rather than cultural barrier. And that actually hampers those population to seek healthcare access. So my question is, have you ever experienced this kind of issues other than Bangladesh? And if you found, how did you overcome this? Thank you.
Maybe I'll attempt and then maybe invite Joe and Miriam. So in my little experience outside, when I was in Somalia, actually, when I was working there, it's rightly like you said, Doctor, there was a lot of religious beliefs and practices that were actually founded because of who they are. The approach we took when I was working for the NGO was really to understand the practice better, to understand the practice better and why the practice was needed, and whether with the religious leaders there was another way to achieve the same impact, but on another alternative option. So for example, a lot of the societies would use physical cutting of a person because the thinking was it was a way to release the spirit from the body, So of course we know that not only does it give physical harm, there's also a mental trauma associated with it. So the discussion was around if the idea of cutting a person physically was to release the spirit, was there another way to actually release the spirit without cutting the person? So I think that's the kind of dialogue you would have to have. It's not sometimes an easy answer, and most often than not, you may have to come up with a compromise where for us as humanitarians or scientists, we will say that it's not really the goal, but at least it will not have the physical harm or mental harm that is associated with it. So maybe Joe can add a bit more. Thank you.
Sure, thank you. I think, in a way, this is bringing us back to the language of a whole of society and whole of government response, right? So it's about recognizing the need to understand who all the different constituents are within the jurisdiction of a healthcare system. And I think it comes to, for example, speaking, as was just being said, to, for example, religious leaders who would be a key constituency, who would be a key stakeholder there. It's also about recognizing that the biomedical system that many of us focus on is not the only way in which people access or seek help or healthcare. So it's also important that we understand, when we're thinking about biomedical responses, where these fit within spaces where there are often plural understandings around healthcare, around what health is, around the ways in which health conditions present. And these might be in ways that are not familiar to clinicians in that particular context, or to nurses in that particular context. So this is a really important part of thinking about culture, religion, but how these manifest and come through in different ways around how we understand health differently. And I think it links back to the earlier question that I think Ursula raised around frontline workers versus higher sort of management, for example. And we've done some work a few years ago in partnership with IOM South Africa in seeing if we could develop a form of training that worked with people in the National Department of Health through to provincial, through to facility management, through to frontline. And with the idea being that we could bring all of these issues into sort of the field of reference for those who are responsible for making decisions around budgets, around what programs are prioritized and so on, as a way to try and encourage them to enter a dialogue with their colleagues working on the ground. Because that's the other big gap, is that often frontline healthcare workers don't have a chance to discuss directly with people in senior management or in national departments of health, for example, about what their experiences are at the local level. So it's just another way of bringing together all of these different positions and opinions and insights to try and develop a best practice approach for everyone. Thanks.
Fantastic, thank you. Miriam, would you like to comment on that at all?
Sure, just briefly, I think that it comes back really to the idea of capacity building and training for cultural competence as being essential for all healthcare providers, whether they're working with migrants or refugees or other populations. And I think perhaps, also building on the point of this is about integration of understanding migration and understanding migrants and refugees' health needs and cultural and religious backgrounds as being just part of essential provision of care. Often, I think the religious beliefs and practices are not only essential in terms of mental health and well-being and a normal part of response to migration or response to trauma or displacement, but also I do, I understand that there are, when you have someone in front of you who may have very, very different belief systems or different religious beliefs, that it would be about going back to those very, very basic principles, which are also within all of the cultural competency trainings around what this person in front of me, what are their ideas, what are their concerns, what are their expectations from this encounter in order to be able to go back to those basics of understanding the person as a whole. And I think that goes beyond, particularly, their migrant status or whether they're a refugee. So I think, again, it's about that holistic perspective and about going back to those basic principles.
Thank you very much. I think we just have a little comment from Arti. We're at 29 minutes. So.
Absolutely, I'll be very brief. Thank you so much for giving the floor. I just want to link the religion and cultural pertinence by sharing a small example way back in 2017, when we had the people from FDMNs coming and Rohingya refugees. There were massive immunization campaigns supported by Ministry of Health. And there were young women, there were adolescents, and it is because of religious connotations that they were hesitant to roll up their sleeves in public space and get the immunization done. And we were addressing the vaccine hesitancies while we realized that this is the cultural issue and a religious issue, which actually goes hand in hand. And a very simple solution, just temporary screens were put up so that once they roll their sleeves, they are not visible in the public view. And it solved the issue. We had immense immunization for actually the numbers jumped. When we were struggling for addressing the vaccine hesitancy, the simple understanding that the culturally pertinent measures can improve the coverages. Thank you for giving the floor.
Thank you very much, Arti. That's all we have time for. I'd just like to close on one fantastic comment from one of our virtual audience members. This is from Davud Pourmazi, and he would like to tell us, providing person-centered healthcare already covers the need for culturally aware healthcare. When we see a person as a whole person and not only a person with a health issue, we get better and more comprehensive health outcomes. So thank you very much, everybody.
Thank you so much for that wonderful closing. And I'd like to thank all the participation online and the very rich discussion we've had, the questions, and also the audience here in front of us. I'd like to thank the speakers. Professor Joe, thank you so much for the time, for being with us. Our colleague Miriam for being online, for adding a lot of richness to the discussion, and to the audience for making this very, very, very interactive session. So thank you so much, and I'd hand it to Santino.
Thank you, Edwin. Thank you, James, for supporting the Q&A. Also today, we were unable to address all the questions, but we are skimming those which are mostly requests of directions, information, sorting out the real questions, regrouping the one related to similar argument, and we're going to provide offline answer to the question. So just to reassure you that we are observing and seriously working on that. Well, third day is gone. Another very interesting day of discussion with wonderful story from countries, and cultural competency could only lead to the tomorrow agenda, which is on research. The two things are extremely linked, not by chance. Today, academic person, the colleague dealing with the research agenda in my office were also guests, because tomorrow will be their day. The element of research for us is very important. The engagement with universities is very important for a number of reasons, not only for the role that universities are playing for the undergraduate preparation, training of healthcare workers, but also for the continuous education after that. The entire work on competency has been done hand in hand with a very, very highly qualified group of academic institutions from all the world that have been collaborating with us. But also, we are looking to the academic institution to gear up collaborations, to university to gear up collaborations for really try to fuel an improvement of quality of research worldwide. And this is very important for the area of health and migration, because to make it simple, is a sort of, in bracket, new area of technical expertise for the health sector. The third element, very dear to me and to WHO, is that we want to try to expand the network of academic institutions working with us, because now there is which is not bad, it's certainly a very positive element, but there is a prevalence of academic institutions from high income settings looking into what's happening around the world. We want to really open the door to other academic institutions, especially from those countries which often are in front line in terms of sending, receiving, or having transit of migrants and refugees, and to team them up with the other academic institutions with whom we are already in business. So tomorrow is going to be extremely interesting, again, with a keynote speech, high-level contributions, and video reportage ad hoc prepared for the school, ad hoc casted for the school, one from Lebanon and one from Sweden, from a collaborating center, the WHO Collaborating Center. Thank you very much again to everybody. Please do not forget to send the evaluations. Thank you.